So, today we will be studying the important images asked in the ophthalmology session. First image is of signs of thyroid ophthalmopathy. In this, we don't need to remember all the signs, we will be only learning about the important sign. The first one is lid signs, Daly-Rimple sign. Daly-Rimple sign is for lid retraction. Daly-Rimple sign is for lid retraction. Then is Von Grafe sign. Von Grafe sign is lid lag of the upper eyelid on downward gaze. Daly-Rimple, their R is coming, so it is linked with the retraction of the lid, and in Von Grafe's there is lid lag. In the lag, G is coming. Okay. Then next sign we will be doing is Gifford sign. Gifford sign is difficulty in everting the upper eyelid. Difficulty in everting the upper eyelid. Then is Enroth sign. Enroth sign is for edema. E for Enroth, E for edema of the lower lid. And Enroth sign is shown in the figure 1. So we also need to remember the image. Enroth sign is edema of the lower lid and it is shown in figure 1. Then is Cocker's sign. Cocker's sign is also known as staring look and it is shown in figure 2 and it is increased lid retraction with visual fixation. Then next one we will be studying is still wag sign. Still wag is incomplete and infrequent blinking. Still wag is linked with the blinking. Then is Geoffroy sign. Geoffroy, we need to remember like this: Froy, F for Froy, F for frowning. So absent of creases. In the frowning, creases are formed. Absent creases in the forehead on superior gaze. Then next we will be having extraocular signs, Mobius sign. Mobius sign is inability to converge and it is shown in figure 4. Then the next important one is figure 5, Goldziher sign. Goldziher sign is deep injection of the bulbar conjunctiva. Deep injection of the bulbar conjunctiva. So what important signs we have done? Daly-Rimple is for lid retraction. Von Grafe is for lid lag. Then is Gifford sign, difficulty in everting the upper eyelid. Then is Enroth sign, edema of the lower lid. Cocker sign, staring look. This one is Cocker sign. Then is still wag sign. Still wag means blinking is less. Geoffroy is no frowning. Like in this, Mobius sign is absent convergence, and the Goldziher sign is deep injection of the bulbar conjunctiva. So this much if we remember, most of these important signs are asked in the questions. We don't need to remember all. It will be difficult for us. Then next image we have of the Oguchi's disease. Oguchi's disease is an autosomal recessive congenital stationary night blindness. It is an autosomal recessive condition and it is also known as congenital stationary night blindness. In this, basically, Mizu's phenomena. Mizu's phenomena is seen. What is Mizu's phenomena? It is dark adaptation test of the patient. In the dark adaptation, we will see the fundus photograph of the patient. In the first one, in the A image before and in the B after the adaptation. The fundus appearance was characteristic of Oguchi disease with grayish yellow discoloration that had normal appearance after 2 to 3 hours of dark adaptation. In this, basically, the dark adaptation is tested, and before the dark adaptation, the fundus will be appearing the grayish yellow. Here in the first image, it is grayish yellow, and after some time, it becomes normal colored. This is known as Mizu's phenomena, and it is seen in Oguchi's disease. Then the next image is of the retina, of the retinal layers. In the retinal layers, we are dealing from inwards to outwards. From the inwards to outward, we have the retinal nerve fiber layer, then ganglion layer, then Muller cell layer, bipolar cell, amacrine cell. Basically, here we are not remembering the cell layers. In the cell layers, we will be discussing in the anatomy section. This is basically about the cells which are involved in the different layer. First of all, we will be having the ganglion cells. And Muller cells are spanning throughout. Muller cell, this large one which is spanning throughout the membrane. Then are bipolar cells and amacrine cells. Amacrine cells and horizontal cells. These will be lying in the horizontal direction. Then In the outward layers, we have rods and cones. Rods and cones are basically photoreceptors. And then at the last, we have the retinal pigment epithelium. Then this next image is of capsulorhexis. It is an important step in the cataract surgery. Here the anterior capsule is being incised. Here the incision is given in the anterior capsule and it is being removed, and it is known as capsulorhexis. Then this is image of posterior vitreous detachment floater. The floater visible in posterior vitreous detachment, and it is also known as V's ring. This was V's ring, then this is Vossius ring. Vossius ring is seen in trauma, in the blunt trauma cases. Then this is the fundus image of retinitis pigmentosa. In retinitis pigmentosa, basically three important things which we will be seeing is pale waxy disc, bony spicules, black bony spicules that are visible here. Then is attenuation of the arteries. Arteries are attenuated. Pale waxy disc, bony spicules, and attenuation of the arteries. Then this is the image of the gyrate dystrophy. Gyrate dystrophy is due to ornithine aminotransferase deficiency, and the treatment of it is arginine-free diet. Gyrate dystrophy is due to ornithine aminotransferase deficiency, and in the treatment arginine-free diet is given. And basically in this the finding is the periphery is destroyed. The periphery is destroyed due to this depositions. So only the central vision or the keyhole vision is left. Then this is the fundus image. It is looking like splashed tomato. Somebody has splashed the tomato. Splashed tomato appearance. It is seen in CRVO, central retinal vein occlusion, and in the hypertensive retinopathy. Then this is the fluorescein angiography image of the Stargardt's disease. In the Stargardt's disease, basically Stargardt's, we have to imagine like in the black sky there are stars. So the background will be dark and the stars will be shining bright. So it is classic dark or silent choroid due to masking of choroidal fluorescence with staining of pisiform flecks. So on the dark background there will be some shiny spots like stars. So it is also known as silent choroid and staining of the pisiform flecks. Then this is autofluorescence is positive in both the Stargardt's and the Best disease. Stargardt's and the Best disease are basically retinal dystrophies. So in the healthy retina we see optic disc and macula. While in Stargardt's disease there will be flecks which will be staining whitish, and then there will be macular atrophy. So this phenomena of staining white or bright of the flecks, this is known as autofluorescence. Then this is egg yolk appearance. Egg yolk appearance, this one is showing the like looking like egg yolk. So this is seen in the Best disease, in the Best vitelliform dystrophy. The two dystrophies which we need to remember are Stargardt's disease and the Best disease. We need to remember the classical appearances. Then this is the image of cystoid macular edema. Cystoid macular edema, in this the fluid is accumulated behind the retina. So it will give the appearance of the cystoid macular edema, like cystic spaces will be there in the macular region, cystic spaces. It is also known as petaloid or honeycomb appearance. It is looking like petals or honeycombed appearance. It is in cystoid macular edema. Then this is the image, fundus image. In the fundus image, what it is shown? Cystoid macular edema. Here also petaloid appearance. And cherry red spot. In cherry red spot like here it is optic disc, and on the macula there is a reddish spot. It is known as cherry red spot. Cherry red spot is seen in many conditions. The few of them are named here, and the mnemonic for it is cherry trees never grow tall. C for central retinal artery occlusion. In the vein occlusion, it was splash tomato appearance. Then T, trees, T for Tay-Sachs disease, N for Niemann-Pick disease, G for Gaucher's disease, and T for trauma. In the trauma, it is known as Berlin's edema. So it is seen in central retinal artery occlusion, Tay-Sachs, Niemann, and Gaucher's. It is metabolic diseases, and then is trauma. This is clear image of cherry red spot. Here is disc and here is macula, and on the macula the red spot is present. Then this is the fundoscopic image of the angiod streak. Here streak like from the optic disc region, and it is known as angiod streak. This is another image like streaks are emerging from the optic disc region. Angioid streaks are basically breaks in the Brooks membrane, and it is seen in pseudoxanthoma elasticum in the most common, then the Ehlers-Danlos syndrome, in the Paget's disease, and in the sickle cell anemia. Angioid streaks are seen in which diseases? Most common is pseudoxanthoma elasticum. Then the next one is Ehlers-Danlos, linked with the collagen and the soft connective tissues. In Paget's disease, linked with the bone and sickle cell anemia. Then these are drusen's. These are shown in the retinal layers. Drusen's is age-related macular degeneration. And one important finding in the age-related macular degeneration is metamorphosia. Metamorphosia, this is basically Amsler's grid test. In the Amsler grid test, patient is asked to see this grid chart, and in this the patient will be not able to see the straight lines. If the patient is not able to see, like, it will not appear like that symmetrical, it will appear as slanting lines or zigzag pattern. So it is known as metamorphosia, and metamorphosia is seen in the age related macular degeneration. Then this is the fundus image of the age related macular degeneration. In the region of the macula there is degeneration. This was disc, and this in the region of the macula there it is degenerated. Then next image is of proliferative diabetic retinopathy, non-proliferative, and fundus image, and these all are images of the diabetes. So first we will see this image. These are the fundus images. In the diabetes, basically we see 4 types of the lesions. First, 2 are in the nerve fiber layer and 2 are in the outer plexiform layer. In the nerve fiber layer, we will be seeing microaneurysms and flame-shaped hemorrhages. And in the outer plexiform layer, we will be seeing the dot and blot hemorrhages and hard exudates. Nerve fiber layer, microaneurysm are visible in this picture, and flame-shaped hemorrhages. And microaneurysm, and in this we will be seeing outer plexiform layer. We will be seeing the hard exudates. Hard exudates are due to lipids, and we will be seeing the dot and blot hemorrhages. Dot and blot hemorrhages, why here? Because in the outer layer the vessels are vertical, so we will see only dots, while in the nerve fiber layer the vessels are horizontal, so we will see the flame shaped hemorrhages. Then this is the image of the diabetic retinopathy. How we will identify? It is not looking like splashed tomato. It is not full red. Here yellowish things are also seen. So yellowish things will be exudates, and these are hemorrhages. Hemorrhages plus exudates. This is diabetic retinopathy. If only red splashed tomato appearance, then it is central retinal vein occlusion, or it will be in the hypertension. Then this is the fluorescent image and geographic image. This is in the non-proliferative diabetic retinopathy. Here the hemorrhages and exudates type things are seen, but here no proliferation of the vessels has occurred. Vessels are straight visible to us. But in this region, in this neovascularization, because the new vessels will be leaky. So in this, the neovascularization has occurred, more darkish spots are visible. So it is proliferative diabetic retinopathy. So this is proliferative diabetic retinopathy, non-proliferative, and this is simple image of diabetic retinopathy. In four lesions which we need to remember: microaneurysm and flame-shaped hemorrhages. Microflame. Microflame is in nerve fiber layer. And in the outer layer we have the dots, and that are hard dots. Hard dots are seen in outer plexiform layer. Then this is the image of epithelial deposits. Here in the cornea we have the epithelial deposits. These are also known as cornea verticulata or vortex keratopathy. These lines like, so this is seen in which drug cases? This is seen in chloroquine, amiodarone, tamoxifen, indomethacin, and in Fabry's disease. Chloroquine is used in malaria. Amiodarone is basically used in the heart conditions, in the arrhythmias. Then tamoxifen is used in the female patients. And indomethacin is used as prostaglandin in the infants and in the other conditions. Then Fabry's disease. So in these all the conditions, the cornea verticulata, that is epithelial deposits, will be seen. Then this is the image of arcus sinalis. Arcus sinalis, what it is? It is this round, so, like peripheral deposition in the cornea. It is in the corneal stroma. These were in the epithelium, in the outermost layer. Then after the epithelium we have the stroma. In the stroma it will be lipid deposits, and it is known as arcus sinalis. Then after the corneal epithelium, then inside it is stroma. Then further we go inside, it is Descemet's membrane. And in the Descemet's membrane, if copper is deposited, then it is known as Kescher-Fleischer ring. Kescher-Fleischer ring, and it is seen in Wilson's disease. Copper toxicity. Wilson's disease, Kescher-Fleischer or KF rings. These are the deposits in the Descemet's membrane. Then this is the image of scleromalacia perforans. Scleromalacia perforans means sclera has become weak. Malacia means weakness, and it has perforated. So it is image of scleromalacia perforans. Then this is the image of ciliary staphyloma. Ciliary body is basically in this region. So if the perforation like thing is appearing and it is small and it is visible in the ciliary region, ciliary body region, then it will be ciliary staphyloma. Then this is the image of dystachiasis. Dystachiasis is basically metaplasia of the meibomian glands. Meibomian glands have undergone metaplasia, and here we see the extra row of eyelashes. This one is the normal row and this one is the extra row of eyelashes. This is the image of fungal corneal ulcer. In the fungal corneal ulcer, non-sterile hypopion will be present. The hypopion will be non-sterile because fungal elements can penetrate the stroma. So they will be producing non-sterile hypopion. Then there will be grayish white dry looking ulcer, and these here, like this is the main ulcer, and here the extensions are present. So fingers like feathery finger like extension will be present. This is the image of dendritic ulcer. Dendritic means geographic ulcer types like dendrites of the neurons, and it is seen in herpes simplex virus. This bluish appearance is due to dye. A dye is used, so it is appearing blue and green for the staining, and it is seen in the herpes virus. And this is geographic ulcer. Geographic means looking like map. Okay. If we use the steroids, basically steroids should not be used in the viral ulcer cases. So if we will be using the steroids, this one ulcer will be converted into this types. Geographic ulcer is due to use of steroids in the viral ulcer. This is, we are coming now to the cataract images. This is the image of Christmas tree cataract. Christmas tree cataract is seen in myotonic dystrophy. Then this is the image of posterior subcapsular cataract, or also known as after cataract. It is the most common complication which we happen to see after the cataract surgery. Here the patient will be complaining of loss of sight again after the surgery. So it is mainly due to posterior subcapsular cataract, means posterior capsule which was left has opacified and again obstructing the vision of the patient. This is the image of Alschnig pearls. It is also linked with the posterior subcapsular cataract. Then this is the image of rosette cataract. And rosette cataract is seen in blunt trauma cases. The other thing which we have seen in blunt trauma cases was Washious ring and the cherry red spot. Cherry red spot also known as Berlin's edema. So rosette cataract, Washious ring and Berlin's edema or cherry red spot. These three things are linked with the blunt trauma. Then this is image of shield cataract. It is looking like shield. So shield cataract is seen in atopic dermatitis. Then we need to differentiate between cuneiform and corniculate. The cuneiform is the wedge-shaped pasties with clear areas between them and extend from equator towards the center. Cuneiform is going towards the center. So these are present in the periphery, and these will be obstructing the peripheral vision. So patient will be not able to see properly when the pupil is fully dilated. And when the pupil will be fully dilated in the dark light. On oblique illumination, these present as typical radial spokes. On distant direct ophthalmoscopy, dark lines against the red fundal glow. So once again I am explaining it. In the bright light, when we go, the pupil is fully dilated. So in the bright light, like when the patient is going on the road and the flashes of light in the night will be visible, so the pupil will be fully dilated and he will be able to see the halos. So this is extending from periphery towards the center. Then this is image of Morgagnian cataract. Morgagnion's color has changed of the nucleus. Morgagnian cataract. It is also known as hypermature cataract. Then this is the image of subluxation. Subluxation are basically two diseases which we need to remember: homocystinuria and the Marfan syndrome. In the homocystinuria, inferonasal subluxation is seen. And in the Marfan syndrome, how we will remember? Fans out. Fans out means fan will be spreading the air laterally and outwards. So it will be superotemporal. Temporal means lateral. Superotemporal subluxation is seen in Marfan syndrome. And other things which we will be seeing: pectus excavatum, dilation of the aorta, and arachnodactyly, long fingers. Then this is image of the optic nerve meningioma. In the meningioma, basically tubular thickening and calcification will be seen. In the meningioma, calcification, this whitish appearance is due to calcium. The bone is appearing white, so whitish appearance is due to calcium. It will be seen in meningioma. While this image is of glioma. In the glioma, there will be fusiform swelling. Here, this speck of calcification will be there and tubular thickening. Here is fusiform thickening. Then this is CT image of the orbital floor. Here the orbital floor is fractured and the orbital fat is coming down. It is known as teardrop sign. And here the inferior rectus muscle. Inferior rectus muscle can become trapped in this. So the action of the inferior rectus. Basically, it is not the action. It is the means opposite direction movement will be impaired. Because when the muscle will be trapped, it will be seen in the contracted state. This is image of Clasion. Clasion is known as hordeolum internum. while the stye is known as hordeolum externum. In the chalazion, the opening will be on the inside. If the opening is on the outside, then it is known as stye. Then this last image, this is of RAPD, okay, relative afferent pupillary defect, also known as Marcus Gunn Robert pupil. Here, when no light is shown, the pupils are equal, and when the light is shown on the normal eye, in the normal eye, the light is shown, then the pupils will be contracting. But if the light is shown in the abnormal eye, then the pupils will not be able to contract. Pupil will be relaxing. Pupils will be dilated. So in normal eye, the contraction is occurring, and in the abnormal eye, here the second nerve or the afferent pathway is defective. So here the pupils are dilated. It will not be contracting. So that's all about the important images in the ophthalmology section. I hope it will be helpful for you. Thank you.